Welcome to Knowledge on the Go, the podcast brought to you by the PI Programs team at Vizient. Medication reconciliation is about making sure a patient's medications make sense. What should stay, what should change, and what should stop, while also catching potential adherence issues. Ekaterina Kossykh-Burrows, clinical pharmacist at Highland Hospital, joins us to share her experience around this work. I'm Shannon Hale, Senior PI Program Director at Vizient, and your host. Ekaterina, welcome to the podcast.
Thank you for having me here. You can call me Kat. I've listened to some of the podcasts and they're fabulous.
To kick us off, Kat, could you tell us a little bit about Highland Hospital?
We are what I would call it as a perfect size hospital. It's about 280 beds. Our overall population is older with a lot of medications. We are part of the bigger system of 5 hospitals. Our biggest hospital is Strong Memorial Hospital, who's our head leading hospitals. We do have our own differences and our own ways of doing it just because our population is different.
You recently took part in a performance improvement collaborative here at Vizient, and it looked at medication reconciliation. What led you to join the collaborative?
The collaborative was such a great way of gaining an insight and first-person knowledge because transitions of care is still a relatively new field, and I've been in it for 14 years, and it's an evolving field. You can pull whatever's published in the system. You can see what the guidelines are, but it's such a better way to actually listen to people who are doing it in real time. There might be such a small thing that somebody says that will never be in the guidelines or never be in the published literature, but they might give you such an insight to improve your own program. That was a huge thing to see them, how they struggle, how they overcame, and those little pieces that they might not even think about presenting your own program as well in it. You're doing something great and you might not realize that you are. It opens up to progress in your own program and prevents a reinvention of the wheel.
It's funny that you mentioned that because even as someone who leads some of the collaboratives here, it's often my favorite part, hearing what others are doing and not needing to recreate the wheel, but seeing something that another organization is doing and saying, well, that's a great strategy. I'm going to try that.
It's validation of what you're doing, plus looking at such a great synergy that will push your program forward.
Totally agree. Medication reconciliation, we've been working with this for years. I remember when I first came out of school, it was a big focus area for us. And it's a very risky time, looking at the medications, making sure they're correct. Does the patient understand them? Your team decided to look at how you prioritize which patients may benefit the most from an admission medication history by your pharmacy technician team. Could you tell us how you decided to look at that?
The first, we had only 1 technician. Right now, we have 3. When we started, we knew there was a need, but at that point, the programs were only developing, so there was a little bit of a pushback and a caution. The way we approached it is we almost overshot what we needed because the physicians were a little bit nervous about the medications, too many hands in the pots. We went into this 2-prong approach because one was the score. The other one was because we have core group of providers in our hospitals, the APPs and hospitalists. Over the years, they got to know us and they have requested certain patients that they see that have potentially a problems. They will send us a request, usually of a complicated question or a complicated patient that has ambiguities prior to admission list. When our technician comes Monday through Friday, they cover our hospital. We'll prioritize the requests from the medical teams first, and then they will use the prior to admission score to pull additional patients that will skew them towards harder patients. They will call the pharmacist, call the primary care offices or nursing homes or VA systems to request the lists. They have 2 sources for their medication histories, plus they will do a patient interview. From that, they will have enough information to update the list. To create a note is pushed to one of our transitions of care pharmacists. They inform the provider or the team on what changes were made, as well as what the active medications and if it's something doesn't match.
You mentioned something that caught my attention, the scoring system. Could you talk a little bit about how that works and about how you came up with that?
Since we are a geriatric hospital, we picked certain things in our score to cue us to the patient that will be most likely to have inconsistencies or missing or extra medication. We pulled the high-risk meds, the insulin, anticoagulant, antiarrhythmics, and seizure meds. We pulled the people that have been in the emergency room in the last 6 months 2 or more times because that will cue us in on something not quite connecting. Heart failure in COPD patients is a big part of the population, as well as GI bleeders and CVAs. So those were part of the scores, but they were big indicators that will cue us in that those patients might have mistakes in their medication lists more likely than the others. Each of those points was assigned a score, like 5 points, that was a little bit more arbitrary. Final score was presented in the column in our list. That was a score that our technician would look at and say, oh, this is a higher score, I will pick. Later on, we did this poster that I presented at the collaboration that we said we really probably need to do a validation of this prior to admission scores. We, in our gut, know that it works, but it would be good to put it on paper and say, hey, we actually do have the data. We went through the prior to admission scores and we tried to track how many changes we had based on the higher score versus lower score. And we definitely had a correlation. Not only we did the score that are specific to our hospital, but we also validated it with data so we know for sure it works.
I love that scoring system. Hypothetically, if I'm a patient that's 66 years old, that's one flag where I'm going to might get a deeper review. 2, if I'm coming back into the emergency room and I was just there 2 weeks ago, I might need to have those medications reviewed. Maybe that's why I'm coming back in. You've come up with that scoring system and a way of looking at that as a potential for my revisit.
We thought of anything that might put patient at a higher risk of readmission. A lot of our problems are tied to medications, and whether it's not filling them, not affording them, not able to take them or organize them. So there's so many reasons. Usually it causes readmissions and it causes a more acuity in your diseases.
You've got the scoring system. You're doing this as people are coming in. Have there been any insights that you could tell us that come to mind? Anything that you've seen?
One of the insights was the thought behind that we're sharing all the records and everything is flowing everywhere. In theory, it should be a nearly flawless system. Because we've been working on it for a while, there are things that came up that people just didn't realize. For example, we have a part of our system that shows us the refills that were filled in the outpatient pharmacies. And at some point, we realized even so they're showing up as refills on this day, if they're close enough, they might be filled, but they might not be picked up. One of the insights that we learned is when we started it, the providers were wary of another hand in the pot. But as we went on, we have such a decent amount of providers in our hospitals that are actually excited about our service and reach out on a regular basis because they realize we have ironed out all of the little wrinkles because we've done it so much and we know where a lot of the little mistakes are going to come. It's easier for us to run through the patient and pick up those mistakes. The expectations of going to an electronic record was that everything will be perfect, but you still need that human factor.
You really hit on something. Technology is going to make everything perfect, but we still have to keep that human factor in there. So important and so key to do that.
Having a dedicated person to do this, it's such a little piece, but such a big part of the healthcare. That dedicated service that takes this little tiny piece that's really problematic sometimes and makes it much better is really helpful.
You hit on it. It has so many repercussions. It could be a cause for me coming back into the emergency room, being admitted. There's so many opportunities for things to go wrong. This is a great system that you've got in an area where we need that human aspect to prevent this. We work with a lot of organizations that may hear this. Is there anything that you know now that you wish you would have known when you first started this work?
being on this journey to perfect the transitions of care. The big thing that we do well is start small and be consistent. We would love to cover all the medicine patients. We would love to promise we're going to do this MedRex 100%. But at the same time, probably being a pharmacist and probably being a little bit of nitpicky, we would love to do it well, to uncover the things that matter for the discharge when people are here as well as when people go home, that will make a difference in the long run. Starting small, being consistent is the key, and covering what you said you were going to cover. When you build the trust with the providers, provide a consistent level of service, and having that feedback from the providers that it's like, wow, this is really helpful. And now I don't have to double guess what you guys are doing. There's a quality product that's coming out of your service and it's helping me, and I can put this order in and I don't have to think about this. The new programs and the expanding programs should be mindful of providing a consistent product. If they have a great feedback, they will use your service more and they will trust that more. Reach out to neighboring programs. A couple of months ago, I came out to one of our area hospitals. They invited me. We sat down and we looked at our process, and I said, this is what I do. It's a chance for me to say, what are you doing? Because you might be doing something that would be interesting to me, whether you're starting or along the process of it, reaching out to other programs and actually doing face-to-face, collaborating locally. And that would be a quick way to improve whatever you're doing.
You hit on 3 huge issues. 1, building trust. 2, learning from others. You're further along the journey than the peer pharmacy that you went to. But this still doesn't mean that we both can't learn from each other. Maybe something said when you were there that a light bulb went off and you thought, oh, maybe I want to try this, at my organization. They're learning from you as well. Starting out small is so key.
Providing consistency and then expanding is great because it's such an overwhelming thing when you start a program. Our boss ran the numbers for the 2025 for the medication reconciliation. Our technicians, when they provide a MedRec, is about 5 per medication reconciliation changes, which the 3 main ones are addition, taking the med off, or changing the dose or frequency. So the big one. Based on the numbers for 2025, on the conservative estimates, were 240 readmissions prevented.
Its impacts on patients' quality of life.
Yes, patients' quality of life. For the technicians, they do the 2 sources, but they also talk to the patients, talk to the family, talk to the providers, reach out to the nurses in the nursing homes sometimes to have a staff that doesn't turn over because they have years of experience. Even when they look at the MAR from the nursing home, sometimes one of my techs will say, something is funny. And we will reach out to that nurse and we will go over, say, did something go wrong? Not to blame anybody, but that will provide a little bit better care in the hospital admission.
I love that you're speaking with the staff at the nursing home to get to what's the root cause. Could this have played a part in what we're seeing?
It's an evolving process. Do we look at the physician order list or do we look at the actual MAR? Did the transcription error occur there and that brought a patient in? Over the time, you learn that those are the places that the mistakes might happen.
Great insights and some great results. I love that 240 piece that you mentioned. Thank you, Kat, for joining us today and sharing your insights when it comes to the medication reconciliation process. And thanks to you, our listeners. Please join us for more knowledge on the go. Subscribe today, like us, and send us your comments at picollaboratives@vizientinc.com.